Hello Malaysia and welcome to episode 11 of Medical Today with me, Jared Rutnam. Of course, we've got a smorgasbord of topics coming your way in episode 11, season 2 to be exacting. But joining us first on every segment is Dr. Navindra Nageswaran, the Group Managing Director of Global Doctors. He joins us on the first segment every week in season 2, and he's joined by Dr. Andrew Mohanraj. Now, if that name is ringing a bell, well, he's been here before on Medical Today. He's a consultant psychiatrist and the president of the Malaysian Mental Health Association. Gentlemen, welcome to the show. Thank you very much for taking time off your busy schedule. Dr. Navin, it's always good to be with you, interviewing someone on a weekly basis. Now, we're going to be talking about mental health today. Well, when we talk about mental health, why is it important that we talk about this subject, especially with the aging?
It's simply because, as what we've been discussing in the last few discussions, that our country, Malaysia, by 2030 will become an aged population with about nearly 15 to 20% of our population will be above 60%. And in line with that, we will have all the mental health conditions.
Right.
At the same time, there's also the aging conditions, but mental health conditions are very predominant in this group of people.
So if we're talking about mental health conditions or components on primary care perspective, what do we need to think about at this point?
I think the first one will be depression, identification, dementia, and basically general well-being of the mental status.
Right.
I think I'll let Dr. Andrew add in something.
Well, Dr. Andrew, can early diagnosis or identification of mental health or health disease make a difference?
Oh, certainly it can. I think when we're talking about the older adults here, of course, the first point of contact for them would be their caregivers or family members. So it is important for family members to be able to detect signs and symptoms of dementia or depression in their loved ones.
So not as a general rule, but most of the time ascertaining the problem would be by the caregivers.
Yes, but there's also some differences here as far as the older adults are concerned, because, for example, in one of the major neuropsychiatric problems seen or associated with old age is depression, and as Dr. Navin just now said, dementia as well. And in depression in older adults tend to manifest slightly differently as opposed to the other age groups. For example, the older adult may not necessarily admit to having persistent low mood. That could manifest in having aches and pains, and or even in terms of the losing or having diminished interest in pleasurable activities in life. The other age groups may manifest this differently, but in the older adult, things could be very simple as losing interest in reading the newspapers every morning, or even watching your 8 o'clock Bernama news, which they've been watching for the last 20 years or so. So these are things that needs to be picked up by the caregivers. And of course, this also requires a little bit of sensitivity on the part of the caregivers.
Dr. Navin, when you talk about aches and pains, you get a lot of people who come and see you, especially elderly patients. When they come with their caregivers, they'll say, "Doctor, I've got pains here and there." How do you kind of make sense of all this?
Sometimes you might not get a correct diagnosis for this pains and ache. It's like fibromyalgia. You don't have a diagnosis.
I was about to say it, but you stole it right out of my mouth.
So you don't have it. So what you need to do is work at the root cause. Sometimes it could be some things that what Andrew is saying they don't want to talk about. They don't want to talk about erectile dysfunction. They don't want to talk about incontinence. But the thing is, their rationale would be on pains, ache, and kind of twist it to another section. So you need to spend time. I think they usually come to the primary care. When they come there, the first thing that you need to do is spend some time. Because firstly, they take time to sit in your chair. Then you need to really spend time.
So while all that's happening, you're watching them. And
yes, you need to watch from the time they open the door and walk and sit with you and talk to you. And you can observe whether they're smiling and how their whole overall perspective to life is taken up.
Now, why do you think some elderly people are affected and others are not?
Well, the ones who are not affected by this are probably ones who are more prepared to face, more prepared to face post-retirement, for example, or more able to face isolation and loneliness, because in the older adult group, certainly isolation and loneliness play a very important role in them learning depression. I use the word learning here because I strongly believe that in most cases depression is learned, but it can also be unlearned. It is very easily reversible, and therefore some people who are able to cope with this loneliness and isolation much more than others. And of course there's also the element of having physical illness along with old age, because people these days tend to live much longer thanks to better nutrition, better accessibility to healthcare and things like that, but they do not necessarily live a healthy, go through a healthy lifespan. So that also complicates matters. So in this particular age group, it is quite complicated, but some people are able to cope with depression, for example, depression much better than the others.
So there's a couple of words being bandied about in this day and age. Fibromyalgia is one of them. Some doctors subscribe to it, some doctors don't. There's also fatigue, which is now being talked about a lot. Do you see that often, do you buy into this whole fibromyalgia and fatigue syndrome?
Well, there's, that has been bandied about quite a bit, but my own view of this is could be slightly different, in the sense that when you look at particularly neuropsychiatric manifestations in the old age, and I'm particularly referring to depression in old age, it's actually quite simple, in the sense that the cause or the stressor or the life events that causes this in old age is very simple. And if you are able to deal with that aspect of it, in terms of loneliness and isolation, accessibility to healthcare, to be connected to others, then it's quite a simple thing, really.
It's a bit of networking, like what we discussed about communication, a little bit of WhatsApp, get onto your phone, speak to people, and all this like sarcopenia. Strength training, you have to do something, because all our activity starts to come down, and as you grow older the activity further comes down, because like what you were saying, what your routines have actually changed. You don't travel, you don't go out often, you don't walk as much as what you do. The number of steps, we count 10,000 steps. As the age going, nobody has actually done a study to find out how many steps they actually take per day. We said 10,000 is
Someone's
good
going to come up with a machine just after hearing this.
Yeah, I think so, which is good, because you need to have that. Then you'll say, okay, as you grow older, as I mentioned it, 1% of our body mass and our muscles are going down every 10 years of the age, from the age of 40. So what will happen when you're in the 80s and the 90s?
So at the level of the care you're giving, if someone comes and tells you, Doc, I don't have the will to do anything, what would you make out of this?
I think it's counseling, and probably get them to speak to someone, and keep them in an environment that's got a community base. Rather than prescribing them a lot of medicines for pain and aches.
Well, that's also probably it should ring an alarm bell here, that that statement that they made could be just the tip of the iceberg. There could be the other problems associated with that, and I think particularly in the older age group now, we must also not rule out the possibility of such a person having depression. Now we know that depression in the older adult is severely underdiagnosed, and that's because of a variety of reasons, because the older adult, usually a typical older adult, will not come out and say that he or she has got low mood or depressed. So
hold that thought. We're going to come back. Of course, we want to talk about anxiolytics too, because the go-to standard these days, my mother and my father is a bit depressed, give them a little something to keep them calm. We'll come back and talk about this just after a short break. Stay with us right here on Medical Today. We've got an interesting discussion going on. We're going to come back and talk about mental health in the aging population. Right here on Medical Today, BNC. Stay with us.
I have a vision correction number, but I'm more than a number. When I'm not enjoying my little sunshine, I'm enjoying my city's modern architecture. My S.Selva lenses go beyond my correction. Their creasel technology shields my eyes from reflections, scratches and smudges for optimal clarity. I'm more than a number. I'm a crystal clear catcher of the perfect image.
See more, do more. S.Selva. Ask your eye care expert for advice.
I have a vision correction number, but I'm more than a number. When I'm not sharing ideas with my colleagues, I'm defending my kingdom on the back of a dragon. My Eyezen lenses go beyond my correction. They keep my eyes relaxed to stay focused and protect me from harmful blue light. I'm more than a number. I'm the never tired Dragon Eye. Eyezen.
Ask your eye care professional. See more, do more. S.Selva.
Hello and welcome back to Medical Today. This is episode 11, season 2. We're currently talking about mental health in aging population, and what we're trying to put together as a message is how to identify, live and manage the problem. So we're talking about mental health in aging population.
And where we left off there just now, I think one of the things that everybody would like to listen is how to detect depression, how to assist people and how to detect depression in the elderly community.
Thank you. As I mentioned earlier, this is to detect depression in the older age group or the older adult it can be a bit complicated, because often it is the person concerned is not going to come out and admit to having low mood, persistent low mood, and because depression or clinical depression by definition means that you have to have persistent low mood for a period of 2 weeks, at least, minimum period of 2 weeks, or a very clear sign of loss of interest in pleasurable activities. Now for the general adult group, it is pretty straightforward. But for the older adult, it is generally very, it's a little bit difficult to detect this, but even by people who are close, who are caregivers or family members, because low mood can manifest as aches and pains, for example.
Yeah.
So the caregiver might take the concerned person to see various doctors to sort out all the aches and pains, and then ultimately find out that there is no real cause for that.
Yeah, but
it's purely psychological.
Therein lies the problem. How do we now define, after Tun has come back to the fore to run the country, how do we now define what's an older adult in the country?
Yeah, exactly.
Well, exactly. I mean,
how did he get himself to this point?
I mean,
at 93 and maintained? Because he must have. This couldn't have happened overnight. It's not just one injection help you fix it. It must be something that
although I'm hoping for that.
And this is something that he has done right all the way, probably from the age of 40 and 50s itself.
Sure. I mean, I think that's well documented that he had, looked after his health, and he had a, sort of a very balanced lifestyle, and ultimately it's lifestyle also that determines the developing of depression and how you.
So it goes back to how do you, as a psychiatrist, psychiatric specialist, define an old age person after the person retires?
Well, if you go by the WHO definition, that is anyone above the age of 65. And of course, economists have got a different definition. Sometimes in some papers they say it's beyond after 60. But the good thing is that you pointed out, you mentioned the word retirement, and that's really very crucial here, because retirement is a major life event. And it does not only mean that you have diminished income, which can result in some financial challenges as well, but more than that, it's also a loss in your social standing for some people. After retirement, generally they are put aside, retired people's opinions are not sought after, and people feel isolated and not connected to the rest.
And also the companies, like, for example, when you're working, there's always a corporate perspective. The corporate takes care of your health. They actually fund your hospital bills, your clinic bills. But there's also a corporate responsibility to take care of their employees and manage their health. There are a lot of companies who actually don't focus on this. They think paying the bills of hospitalization is important, but not about managing their health. So I think that's a very important part that corporate can play a role.
And in addition to that, in the older age group, I mean, while people tend to live longer these days, this does not exclude the possibility of other physical illnesses that come along the way. And some of these physical illnesses can also have a bearing on mental health. For example, cancer or cardiovascular problems have got a very clear relationship with mental health and depression.
Yeah, but I guess going back to what Dr. Navin is saying, people should generally be moving, constantly moving, and keeping yourself on your toes would ensure that you kind of prolong.
I fully support that statement, because that's what that needs to be. People need to be connected, to be valued, and this will result in them having a more zest for life.
I'd like to pick up on a word he said. He said connected. And a lot of people who work within the broadcast industry, like if you watch the CNNs, the BBCs of the world and whatever, you see that the best commentators or best talk show hosts would be in their 60s, in their 70s.
Exactly.
A little something we don't practice in Asia, because we are very dependent on looks and how that appears or that turns out on TV. Now you say, so people after they're 50 and you say you're no good for broadcast and you kick them out, then they start declining because they are not in the limelight anymore and all. Have you seen something like that, or even you, Dr.
Definitely. I mean, this is not where this is not a pilot who's taking 300 passengers. The intelligence is all in the experience that you acquire during the whole period. So it's much easier for you to actually continue that on the broadcast industry. You should continue it. We should maybe introduce that.
And that's a good point, because I think we need to harness the wisdom and the experience of people who have retired, and they've got so much to offer. There's really no need to put them aside and to think that their opinions are of no value anymore.
Right.
And the other point that you mentioned, and you asked why some people can handle post-retirement blues, if you want to call that, how do they handle that better than others? And I think that also has a variation in between, if you compare women and men. For example, women generally handle it better. And I always use the example of Tan Sri Rafida Aziz. And she has said that even when she was a cabinet minister, and we all know that she was quite a high-profile cabinet minister then, she used to take time off. Whenever possible, she used to cook for the family. And she did household chores as well. So it was easier for her to, in the transition period between being a high-profile politician to getting into...
I think in the last few minutes that we have, what we need to address is talk to healthcare providers or caregivers and those who are caring for their parents on their own without, or rather caregivers who are doing it because they're family. Not professional caregivers, but family and professional caregivers. What would be your parting advice, both of you, to those of us who are caring for our parents?
Well, I think for one that, the family members who are caring for parents or spouses caring for their partners need to also take stock of their own psychological well-being and understand that this is not an easy task. It can lead to burnout, it can lead to disappointment, and therefore my advice to them is to look after their own mental health needs as well. There's a high a chance of caregivers developing depression themselves.
What are the telltale signs?
I would like to add something else.
Yeah, sure.
The telltale signs. I think the person who's growing old should be also addressed, should be taught. The caregiver should make them be independent. Do not make them dependent on you, because like what you were just mentioning about putting the socks on. Sometimes you go, if there is a maid, but you make them do it themselves, because when they learn to be independent, they stimulate their mind, they stimulate their strength, they stimulate their ability to do things.
While you say, make them do it, I think, and this is just my personal opinion, how we tell them to do so, and it's put on your socks, do it on your own, do it on your own. I find that a little bit, hitting on it's not very good on the ego.
Yes.
So how do we go about doing things like that?
I wouldn't say put it on. Don't be around.
Yeah.
Because when there is people, you always would depend. But if you cannot stand and watch, so the best is you allow them to be independent. Then later when you come in, then you look at it. Because telling them definitely is a no-no. Telling them to put the socks on, but don't be there when the time to put the socks on, and then you come back and see they will make their achievement themselves. I mean, that's the belief. Psychiatrically I don't know how that works, but their mind will then focus. It's survival. You will have to do this. If nobody is there to make a cup of coffee, you will make your own coffee.
But sometimes it's not just purely behavioral. While I understand that there's there's some element of truth in what you say, but sometimes it's not that it's being done on purpose or intentionally. It's the fact that there is an underlying psychological condition that that keeps them unmotivated to do things.
Well, we can go on with this discussion. It's a fantastic discussion, but we have to stop at this juncture. Datuk, thank you very much. It was a pleasure having you on the show. Dr. Navin, stay with us. We always like you being here. Of course, you'll be here joining us in the next episode to, of course, delve more into problems of the aging and giving us insights on a weekly basis. Thank you very much for that. Stay with us. We're going to take a short break, and when we come back, we've got more for you right here on Medical Today.
I have a vision correction number, but I'm more than a number. When I'm not teaching courses, I'm taking steeper grades and tight corners. My SLR lenses go beyond my correction. They make my vision as sharp as my reflexes to capture every detail from near to far at any speed. I'm more than a number. I'm a rapidly focusing champion of courses.
See more, do more. S.Selva. Ask your eye care expert for advice.
I have a vision correction number, but I'm more than a number. When I'm not enjoying my little sunshine, I'm enjoying my city's modern architecture. My S.Selva lenses go beyond my correction. Their creasel technology shields my eyes from reflections, scratches and smudges for optimal clarity. I'm more than a number. I'm a crystal clear catcher of the perfect image.
See more, do more. S.Selva. Ask your eye care expert for advice.
Hi there, and thank you very much for staying with us right here on Medical Today with me, Jared Ratnam. We just spoke about mental health in the aging population. We now are going to move on to advancements in IVF technology, and over the last 2 decades, we've seen a lot of strides in regards to infertility problems and how we are overcoming it, bringing about a lot of babies being born on Earth. Now, is that the only options? There are lots of options. And to talk about this, we have our on-site host, Nurata Amin, who spoke to Dr. S.Selva, a resident consultant, obstetrician and gynecologist from Makota Medical Center. They were joined by a patient, Ms. Lee Siu Fa, talking about infertility and gynecology, or rather its disorders, and how to overcome it and treat it. Let's take a look at that interview.
It has been more than 4 decades since in vitro fertilization, IVF, was introduced. Despite the improved success rates of assisted reproductive technologies, the argument for performing laparoscopy as a part of the infertility over the recent times are gaining popularity with success rates. Thank you for being with us on Medical Today, Dr. Selva. So could you share the movement of technology in recent years over gynecological diseases?
Okay, the first baby, Louise Brown, was born in 1978. So that's almost 4 decades ago. She turned 40 last year, so she's 41 this year. So in vitro fertilization has improved tremendously over these last 4 decades. At the beginning, success rates were very low, but now with improved technologies, we have very, very good success rates. But in certain gynecological diseases, we need to perform surgeries to correct the disease before we move on to do, say, IVF or for the patient to conceive. And that's where the other technological advancement is, which is laparoscopic surgery or keyhole surgery, which will be able to improve pregnancy rates further in infertile patients.
Yeah, that's a good one. But what is laparoscopic surgery in the first place?
Okay, traditionally, when we talk about surgery, we are looking at cutting. We either make a vertical cut or a horizontal cut. That's the impression that you get when you talk about surgery. But in laparoscopic surgery, what we do is we make small incisions, very small incisions in the abdomen. The biggest usually is only 10 millimeters, or 1 centimeter. Then the remaining are 5 millimeter holes, and through that we can do all kinds of surgeries, very different types of surgeries. That is what we call as laparoscopic or keyhole surgery.
So on top of that, why would you encourage your patients to undergo laparoscopic surgery compared to other kinds of surgeries?
Okay, there are many advantages of laparoscopic surgery, especially in patients who are trying to get pregnant. Now, one of the biggest advantage, one of the difference between laparoscopic surgery and laparotomy or open surgery is that in open surgery, we make a big cut, we put our hands in and perform the surgery. Whereas in laparoscopic surgery, we are making a few small incisions, and through that incisions, we are performing surgery. So we are not placing our hands in the abdomen. So the chances of what we call as adhesions, the intestines getting stuck to the uterus, the fallopian tubes, the ovaries, are far lesser in laparoscopic surgery than in laparotomy. So that's the reason why if you perform laparoscopic surgery for a patient who is not having difficulty in getting pregnant, their advantages is tremendous, because the chances of them getting all these adhesions will be lesser. They can get pregnant on their own without even IVF. That's the benefits of laparoscopic surgery, especially for infertile patients.
Right. So in detail, how is laparoscopic surgery performed? Okay.
Traditional surgery, as I said, you make a big cut, you look down at the abdomen or the pelvis, and then you perform the surgery. Whereas in laparoscopic surgery, we are making small incisions. And what we do is, the first incision, we usually make it in the belly button, inside the umbilicus. Okay, we put in a tube called a trocar, and then we put in a telescope and attach the camera to the telescope. And through this telescope, we are looking the contents of the abdomen and the pelvis on a television monitor. So we are not looking down in the abdomen, we are looking at the television and looking and performing the surgery. So now that we have the view of the pelvis and the abdomen on the television screen, we place in another 2 or 3 incisions, place in instruments, and through that instruments, looking at the television, perform the surgery. So it's entirely different compared to laparotomy. So laparoscopic surgery, basically we are using a camera, a telescope, to look into the abdomen and then perform the surgery.
Right. Okay. So Yeah, you've been mentioning a lot about the advantages, but I think among others. So what are the disadvantages, the other advantages as well of laparoscopic surgery?
Yeah, the biggest advantage...
Any side effects?
I will talk about side effects. Well, let's talk about advantages first. Let's talk about the good news.
Yes.
So, first is, nobody likes a big cut. If you have a big cut, you will have a lot of pain. Okay, so if you make small incisions, then the pain factor, post-operative pain, is lesser. So all my patients who have undergo laparoscopic surgery, they go back the next day, as opposed to if you do a laparotomy, they will suffer a lot of pain for a few days before they go back. So pain, nobody likes pain. So laparoscopic surgery, the pain is far lesser than laparotomy. Of course, nobody likes big scars in the abdomen.
Yes.
All right, so cosmetically, laparoscopic surgery will be very, very good. In fact, nowadays we can even do something called single incision laparoscopic surgery, which means we just make one incision in the belly button, put all the instruments through the umbilicus, and then do the surgery. So you can't even see any incisions. You can do something very big, major, and still have a scar hidden in the umbilicus. So cosmetically, it's fantastic. That's
Now I'm imagining the diameter,
okay.
the size of it.
It usually is about 10 to 15 millimeters in the umbilicus. So this is the second biggest advantage. Of course, the patient, because of less pain, they can get back to work faster, they can go home faster, they pass wind faster. Nobody likes to have wind in the abdomen, especially when you do a laparotomy. And the other biggest advantage that I said earlier is that the chances of adhesions, especially in infertility, infertile patient, is much lesser. So the chances of them getting, for them to be able to get pregnant on their own is far better when they undergo laparoscopic surgery than laparotomy. So these are the advantages of laparoscopic surgery.
Right. So, being a woman myself, of course, what are the different types of women conditions for which laparoscopic surgery can be performed or cannot be performed?
It all depends on the skill of the doctor. Okay, the more skillful he is, the more surgeries he can do by laparoscopy. But generally, the surgeries that we do, the diseases that we do laparoscopic surgeries are fibroids, ovarian cysts, that means water cyst or chocolate cyst in the ovaries, diseases like endometriosis. These are common conditions that we do laparoscopic surgery. Patients who have difficulty in conceiving, for example, the fallopian tubes are blocked, we can go in by laparoscopy and clear the block. Of course, the more advanced surgeries are removal of the uterus. Even for cancer patients, we can do by laparoscopic surgery. So there's a wide variety of cases that, women's diseases that we can deal with laparoscopic surgery.
Right, doctor, how about the women conditions, the level or the stages? Is it during the early stage or towards the chronic stage, then only perform laparoscopic surgery?
We don't operate on every gynecological conditions. There are some conditions that don't need operations. For example, a patient's fibroid is small. Even if she wants to get pregnant, there's no necessity to do the surgery. But if we think that it is going to interfere in her chances of getting pregnant, then we will advise surgery. The more chronic the condition is, for example, if a patient has got a severe endometriosis, then surgery is advisable before we proceed to say IVF or a patient to try to get pregnant. So we will assess. It's not that every patient with every condition we want to perform surgery, but if the condition requires surgery, laparoscopic surgery in my hands will be the first choice as opposed to performing laparotomy, because as I said, the benefit of laparoscopic surgery, especially in infertility patients, her chances of conceiving on her own, even without say assisted reproductive techniques, will be better. So that's the reason why I would promote laparoscopic surgery.
All right, but since you're already at it, how does it benefit an infertility patient?
As I said, besides the fact that it's less painful and cosmetically it's better, the chances of her having adhesions, that means post-operative adhesions. Adhesions means the intestines getting stuck to the tubes, the ovaries, will be far lesser. So that means she will have a better chance of pregnancy. That is the biggest advantage of laparoscopic surgery when we are operating on infertility patients.
Okay, so we have IVF, we have laparoscopic surgery, right? So when will you consider a patient who needs IVF instead of laparoscopic surgery?
That's a very good question. The reason is because we as doctors, sometimes we have this dilemma as to when the patient has a certain disease, which will be the better choice. My policy is always the age of the patient. If the patient is older, when we say older, it's more than 37, say 37, 38, 39, 40, sometimes surgery will not be beneficial for these patients. So we probably move to do IVF earlier than in a younger patients. For younger patients with gynecological diseases like fibroids, endometriosis, I would recommend laparoscopic surgery, because my aim is actually for me to perform the surgery and then for the patients to try to conceive on our own instead of moving on to IVF. But sometimes even in younger patients, if the disease is very advanced, we may need to do the surgery and then proceed to IVF. Sometimes I may even consider that this patient does not require surgery but move on straight to IVF.
Right. So IVF, in vitro fertilization, what is it actually, doctor?
Okay, basically for pregnancy to occur, first of all, there must be sperms and there must be egg. And there must be a place for the sperm to meet the eggs, which is the fallopian tube. Now, if there is certain conditions that causes these two not to meet, for example, the husband's sperm count is very low, or the lady is not producing eggs, or there's no place for the eggs and the sperm to meet, then we have to move on to IVF. So these are the conditions in which we perform IVF. The absolute reason is if both the tubes are blocked, then there's no place for the sperm to meet the eggs, then we have to do IVF. If the husband's sperm is very, very low, then the sperm is not strong enough to reach the egg, or the patient is not producing eggs properly, then we may need to move on to IVF. So these are the common reasons why we do IVF.
So how about like few first miscarriages?
Miscarriages are different reasons. Miscarriages usually is because when the egg meets the sperm and the embryo is formed, the embryo has got a problem. And that's the reason they miscarry. That's one reason. Or maybe there's some defect in the uterus that's causing the miscarriages. So we need to study the cause of the miscarriages. And it doesn't mean the lady has got multiple miscarriages, she must do IVF. And IVF will not improve her chances of miscarriage. You understand what I mean? So it is not necessarily that the patient has multiple miscarriages, we have to do IVF. So the concept of IVF is that we are actually stimulating the woman to produce eggs. We collect the eggs, bring it outside, and we fertilize the eggs with the sperm in the laboratory. And that's why it's called in vitro. In vitro means outside the body. Fertilize the eggs and the sperm, and then put the embryos back into the uterus.
Right.
Okay, so that's the whole concept of how IVF is performed.
All right, this is the fun part, okay? Last but not least, just yes or no answer, doctor. Is IVF pregnancy high risk?
No, it is not.
Do IVF pregnancies have a higher miscarriage rate?
No, it is the same as normal pregnancy.
Right. Can IVF cause birth defects or increase birth defects?
It doesn't increase birth defects.
Thank you, Dr. S.Selva. For more information on the above topics and answers, do contact the good doctor. So this is Medical Today. I'm Antam. So, what circumstances that convinced you to undergo laparoscopic surgery when there was already alternative or conventional treatment back then?
Yeah, I was diagnosed endometriosis in year 2000. What I understood from doctor that this laparoscopy is a keyhole surgery. It is very safe. Okay, small hole. Okay, then less pain and shortened recovery. So when I first heard about this laparoscopy, I think it is perfect because I can go back to work very earlier. So without any further consideration, I just opt for laparoscopy, not conventional methods.
Right. So that was your first time, right?
Yeah,
your first
time.
experience.
Yeah.
So can you share with us your fears, your emotions, your hope, and your experience during the laparoscopic surgery?
Of course, I believe that anybody who is undergoing surgery would be very worried. My main fear about this surgery is the outcome of the surgery, whether it is benign or malignant. Basically, I have no fear to undergo the surgery because I have full confidence with Dr. S.Selva. He is the best. Yep.
So how was your post-surgery experience?
Well, I think I recovered very fast within 2 weeks, and I went back to work after that.
Seriously?
Yes.
So how did the doctor react to that? Is it normal?
It's normal.
It's normal.
Yeah, it's normal. Yep.
Okay, so would you recommend laparoscopic surgery to your friends, and when do you think you should actually recommend to them?
Of course, I will recommend and share my experience and recommend to anybody who need it anytime. Yes,
Okay.
because I find this technique is very good.
Let's say, like for example, how would you actually know that you need laparoscopic surgery?
Because
Let's say before they need to see the doctor, maybe from your experience from a friend.
they need to consult the doctor. I
Oh,
think,
they need to?
Yes.
All right.
Whether it is suitable to undergo laparoscopy. I think laparoscopy is the latest technology. It's very good compared to the conventional methods.
So you do need, of course, a decision made by the experts, yeah?
Yes.
Okay. So what were your worries and your expectations when you were going through IVF? It was your first time? You had 3 times? I
Yes.
think. 10 years ago?
Yeah, 10 years ago. Of course, the expectation will be, I want to have a baby. I want to conceive. Okay, I went through IVF 3 times in 3 years in a row. Okay, I think the main fear will be the physical suffer. It's not only from physical suffer, mainly will be more on mentally suffer, because we have to go through the whole procedure. It's not because we can afford to pay the whole total cost of the IVF procedure. It's whether we can go through. It's whether we can, our eggs is big enough, or the embryo is healthy enough, or what would happen after the transfer, whether I can conceive or not. But finally, I conceived in my 3rd time IVF.
Congratulations!
Yeah, thank you.
So, son, your daughter?
Son, he is 7 years old right
7
now.
years old. What's his name?
Kaylen Chua. Kaylen.
Hello, Kaylen Chua. All right. Okay, have some coffee.
An interesting interview indeed. That was Nuratha Amin speaking to Dr. S.Selva, a resident consultant, obstetrician and a gynecologist. And they also spoke to a patient, Ms. Lee Siu Fa, who talked about her problems and how she had overcome it. All that happening at the Makota Medical Center with Dr. S.Selva. We're going to take a short break, and when we come back, we'll move into our video of the week. We're going to be talking about rheumatoid arthritis and systemic lupus right here on Medical Today. Stay with us.
I have a vision correction number, but I'm more than a number. When I'm not sharing ideas with my colleagues, I'm defending my kingdom on the back of a dragon. My Eyezen lenses go beyond my correction. They keep my eyes relaxed to stay focused and protect me from harmful blue light. I'm more than a number. I'm the never tired Dragon Eye. Eyezen.
Ask your eye care professional. See more, do more. S.Selva.
I have a vision correction number, but I'm more than a number. When I'm not teaching courses, I'm taking steeper grades and tight corners. My SLR lenses go beyond my correction. They make my vision as sharp as my reflexes to capture every detail from near to far at any speed. I'm more than a number. I'm a rapidly focusing champion of courses.
See more, do more. S.Selva. Ask your eye care expert for advice.
Hello Malaysia and welcome back to the final segment of Medical Today with me, Jared Ratnam. Of course, we did talk about SLE, the acronym for Systemic Lupus Erythematosus. Well, that's a little something we're going to talk about later or maybe next week. I'm going to give you a heads up about that as we end the show. But in the meantime, if you do have any questions for us, as always, send your questions to ask@medicaltoday.my. That's ask@medicaltoday.my. What are we looking for? We're looking for questions you need answers to, or if you'd like for us to have someone on the show, please send us an email. Send it to ask@medicaltoday.my. Next week, our topic is going to be rheumatoid arthritis and systemic lupus erythematosus, better known as SLE. We'll be joined by Dr. Lau Kai Po, consultant orthopedic and trauma surgeon from the Regency Specialist Hospital, with Dr. Shalini Ramanujam. She's a consultant physician and rheumatologist, and she's from Makotha Medical Center. Both of them will be joining us right here on Medical Today. On that note, I'm Jared Ratnam signing off. You have a fantastic day ahead and a great week. Bye-bye, and thank you for staying with us right here on the Bernama News Channel.